Welcome to AETCM. Today, I'll be presenting a case of a 65-year-old male with no known comorbidities who came to the ER with complaints of sudden onset breathlessness since morning, associated with right-sided chest pain, which was sharp in nature, aggravated on deep inspiration and while coughing, which was non-radiating. Patient also gave a history of a mild dry cough for the past 2 days. There was no complaints of chest congestion, fever, hemoptysis, rhinorrhea, sore throat, loss of appetite, or loss of weight. Past history: there was no recorded histories of such episodes in the past. No history of bronchial asthma, COPD, pulmonary tuberculosis, allergies, COVID, or malignancy, and there was no history of any surgeries or hospitalizations. There was no significant family history. Personal history: patient had adequate sleep and appetite with regular bowel and bladder habits. Patient was an LPG gas transporter and cylinder transporter and supplier by profession, and he was a reformed smoker who stopped smoking 20 years back. Patient had no recent history of travel or any flight travels or high altitude destination travels, and patient is not on any regular medications. So, based on a summary of my history, a 65-year-old male with no known comorbs, with sudden onset breathlessness and right-sided chest pain, and a reformed smoker. So, patient had a right-sided pleuritic chest pain, and my top differential diagnosis for this would be a right-sided pneumothorax, because the patient had pain, shortness of breath, and the history of smoking associated with it. The other differentials could be pulmonary embolism, given the sudden nature of shortness of breath, or it could have been a pleuritis due to the pain, but there was no history of viral prodromes or any infections prior to this.
Other reasons of acute breathlessness other than these two are most applicable for this condition.
Yes.
Other reasons for breathlessness, sudden onset of breathlessness.
So, if there's an underlying COPD or asthma, an acute exacerbation could lead to breathlessness.
Okay.
Other than that, any cardiac
Pulmonary
edema.
Okay. Foreign body aspiration.
Yes, sir. Okay. So, based on my history, I'd like to examine the respiratory system. So, general examination: patient was conscious, oriented, with no pallor, icterus, cyanosis, clubbing, or pedal edema. Vitals: saturation: patient was maintaining a saturation of 96% with 2 liters oxygen via nasal bronchs. Heart
Before
rate,
that, before starting oxygen?
Initially, patient maintained a saturation 86% in room air.
Okay. A
heart rate of 85 per minute, a BP of 150 by 100 millimeters mercury, and a respiratory rate of 20 per minute. On inspection, the chest wall is bilaterally symmetrical with no spinal or sternal abnormalities. The trachea appears to be shifted slightly to the left, and the chest movement was decreased on the right side.
That is trial sign.
So, the trial sign is
I am asking a pulmonology PG, not an emergency medicine PG. Don't answer. Trial sign.
The palpation.
I don't. I am asking.
Yes, sir. Where you place your index and the ring finger on the on the sternal heads of the clavicle. Sternal heads of the clavicle, and with your middle finger, you trace the trachea downwards, and then you palpate the spaces between the trachea and the sternal.
It's only MBBS question. Trial sign. One side of the sternocleidomastoid will be prominent. Opposite side, trachea will be deviated. And you can easily insert your finger to the area where the trachea is moved opposite side. That's a very simple sign where you can see trachea is deviated to either side or not. That is trial sign. What is tracheal tug?
Sorry?
Tracheal tug. So the basics of respiratory system examination. Tracheal descent, tracheal tug. Have you heard about that? What is it? What is tracheal descent? In an acute breathlessness condition, you can see the trachea is moving down properly. Tracheal tug is seen in. Trachea has got a lot of clinical findings. Tracheal descent. is seen in aortic aneurysm. Okay, where the arch of aorta, you got aneurysm, when it expands, you can see each pulsation, the trachea will move up and down. Okay, trachea is a very small thing, but it has got a lot of clinical findings.
Yes, sir.
Okay, you should learn all this things.
Yes, sir.
Since you are a pulmonologist, I am telling. If you are an emergency medicine PG, we should never talk, no? We should talk only how to intubate, airway management. Here you should learn, because examination they will ask all these things.
Yes, sir. On palpation, the inspectory findings were confirmed. The trachea was slightly deviated to the left. The apical impulse was located in the left fifth intercostal space, half-inch medial to the midclavicular line. There was decreased vocal fremitus on the right side. On percussion, there were hyperresonant notes on the right mammary.
You tell me some conditions where percussion is contraindicated.
This one, rib fractures,
Okay, rib fracture we should not.
friable tumor.
Hemoptysis. Hemoptysis is one condition where you are not supposed to do all these things. Okay. Just auscultate and keep quiet.
Okay.
Because you may be inducing some more bleeding.
Okay, sir. And the notes were hyperresonant on the right mammary, right infraaxillary, interscapular and infrascapular regions. On auscultation, there was absent breath sounds on the right side.
Tell me the reasons for absent breath sounds.
So,
Reasons.
there is a pneumothorax,
Pneumothorax. Hemothorax. Pleural effusion.
impediment.
Then
Mass.
mass normally produces some sort of bronchial breath sound, pneumonia, mass. But mass with something added to that can produce absent breath sound. That is the thing you should
With obstructed
collapse, obstructed bronchus. Mass or consolidation with obstructed bronchus can have reduced breath sound or absent breath sound. Okay.
Obesity.
Obesity, if you are not able to auscultate, means that is our problem. That is not patient's problem. Obesity, you will get no breath sound, you will get difficult.
Yes, sir. So based on the history and the examination, I'd like to come up with a diagnosis of a right-sided spontaneous pneumothorax. In the ER, an ABG was done on arrival.
Pneumothorax is one part.
Yes.
See, patient is in distress or not? Not having distress.
There was no signs of distress, but all the patient was having desaturation.
Patient had desaturation. After starting oxygen, it has improved. That's
Yes,
all. Okay, he is not in distress, but the patient had desaturation.
On arrival, a ABG was done.
What are the signs of tension pneumothorax?
Hypotension, elevated JVP, TAC,
One more.
and
Reduced breath sounds. Which other condition can mimic tension pneumothorax? Huh? Huh? Cardiac tamponade. Okay. Cardiac tamponade also you can get same finding. Absent breath sounds can be there only on that side. Then muffled heart sound, hypotension, raised JVP. Okay. So similar type of findings, but muffled heart sound is extra.
yes, sir. On arrival, an ABG was done, which showed mild respiratory alkalosis with reduced partial pressure of oxygen. And next, an USG chest was done, which showed absent lung sliding with absent lung sliding, which was suggestive of a pneumothorax.
Okay.
Next, a chest X-ray was.
What is seashore sign?
Seashore sign. Basically, when we see a normal lung, the pleura will be moving, because of which there will be this seashore sign. Whereas if there is a pneumothorax, then there will be no movement of the lung, so we see a barcode
sign. So that also you can explain if you know that. But
In M mode, we'll normally have
Motion mode.
normally we'll have a seashore sign, but in a pneumothorax, we'll get a barcode sign.
Okay.
And next, a chest X-ray, PA view was done, where there was a visible pleural line with absent lung marking peripheral to the pleural line.
Okay.
on the right side, and the right side was hyperlucent compared to the left.
Okay. What may be the reason? One side pneumothorax, other side is hyperlucent.
Same side.
Same side.
Same side hyperlucent.
Okay. Other side was normal.
Normal, sir. There was no mediastinal shift, which would have been the case in tension pneumothorax.
Okay.
And there was no diaphragm flattening noted yet.
Okay.
So after this, we did the basic blood tests with a CBC, a PT-INR, pre-op serology, and we started the patient on high-flow nasal oxygen via a non-rebreathing mask.
What is the need of oxygen here?
Sir, the basis of providing high-flow oxygen is to reduce the to reduce the partial pressure of nitrogen in the alveoli and the blood, which leads to nitrogen washout from the air trapped.
Okay.
So we started the patient on high-flow nasal oxygen, and then according to the BTS guidelines of pneumothorax, we first ruled out tension.
BTS is?
British Thoracic.
British Thoracic.
So according to the BTS guideline, we first ruled out tension pneumothorax, and then we had to either figure out it's a primary or secondary. According to the guidelines, a male over the age of 50 with history of smoking falls under secondary, and
What may be the reasons in COPD for pneumothorax?
so the M-phase segment is bulle ruptures.
Bulle rupture.
So based on that, then we and since the patient had desaturation with oxygen support, we initially kept him on high flow nasal oxygen for 24 hours and repeated a chest x-ray. But since there was no resolvement and in fact worsening of the pneumo, we proceeded with an ICD insertion for the patient.
What are the indications for ICD in pneumothorax?
Sir, if it's any secondary pneumothorax in general warrants a much more aggressive approach. And if the depth of the pneumothorax is more than 2 centimeters or the patient is symptomatic, we go ahead with an ICD insertion. And if it's less than 1 or 2 centimeters, but if it's worsening over time or it's not resolving, we proceed with an ICD.
After putting ICD, what all things you have to take care?
Sir, after an ICD, we check for column movement and oscillation of the
Air column. Air column with cough, movement of air column. And suppose there is bubbles coming in that.
So if it's more
bronchopulmonary fistula formation. Okay.
For the patient, we repeated an X-ray 3 days later, which showed some resolvement, and there was no movement present. So we clamped the tube for 24 hours, repeated an X-ray, and then the ICD was removed.
Okay.
So to diagnose the underlying pathology, we got a cardiothoracic surgeon's consult who wanted a CT after the lungs have completely expanded to go ahead.
How do you manage tension pneumothorax?
So for tension pneumothorax, we do an emergency thoracocentesis either in the second intercostal space, the mid-clavicular line, or in the fourth or fifth in the
What is the current ATLS guidelines? Fourth of it. Second, still some doctors practice it, but ATLS is in the fourth or fifth space. Okay, there is a difference between guidelines. ATLS is a trauma guideline. There it is mentioned as fourth or fifth.
Yes, sir.
Okay.
So other than that, based on the X-ray, there are 2 formulae used to calculate the percentage of pneumothorax. Either the Light's formula or the Collins formula. So the Light formula is we use the diameter of the collapsed lung divided by the diameter of the hemithorax. Cube of both. And in Collins formula, we use the distance between the apex of the chest, the thoracic cavity to the apex of the lung as one measurement, and we take the midpoint of the collapsed lung to the lateral thoracic wall of the upper and the lower segments, and then we use that to calculate. Collins was found to be more accurate compared to like.
What is hydropneumothorax?
Sir?
Hydropneumothorax.
So the presence of both air and fluid level.
In X-ray, how do you identify that?
So you will find an air fluid level in the
straight line.
Yes.
Okay, flat line in the fluid.
Yes, sir.
Okay. What is Cohen test? Succussion, splash, Cohen test. All these things you learn in MBBS. Cohen test. So these all things are fancy tests done in clinical examination, not very useful in clinical practice in emergency room. But you may get questions like that. What is coin test? What is succussion splash? Or done in one is done in, both are done in hydropneumothorax. Okay. You have to learn all these things. It is not useful for us, but even then you should learn. Anything else you want to tell? You tell something. Nothing else. You want to talk something? You have any doubts? You can ask him. Nothing. No doubts. No doubts. Okay. Thank you.
Thank you, sir.